So the goal will be to make this high yield. So we'll throw a lot of stuff out, but it hopefully will all be pretty mix-app worthy kind of stuff. So we're going to start with the vasculitides, and here we're dealing with the primary vasculitis syndromes. I'm going to ignore vasculitis associated with malignancy and infections and with other connective tissue, with underlying inflammatory diseases like rheumatoid arthritis. Those are for room boards, not for Ural's boards. So vasculitis, broadly defined, is simply inflammation and necrosis, damage of a blood vessel with subsequent impairment of blood flow. So that can either be because your blood vessel ruptures and you get blood cells leaking out, and the blood can't get downstream, or a thrombosis, most typically. Just mentioned that. Thrombosis causes ischemia, infarction of dependent tissues. And then these folks who get vasculitis, these vessels are they're never the same. Once you've had vasculitis in a vessel, that vessel is prone to get atherosclerotic disease down the road, probably due to endothelial damage. So there's lots of different ways to classify the primary vasculitides. The easiest is probably by vessel size, although this is far from perfect, mainly because there's so much overlap. So yes, these are mainly small vessel vasculitides. Microscopic polyangiitis is mainly a medium vessel vasculitis. Giant cell is mainly a large cell vasculitis, but these classifications are not great because there is overlap. Usually we say at least one size. Feel free to stretch out by one. So if you have a temporal arteritis patient with medium vessel involvement, that's fine. We're okay with that. If you have a pan patient with small vessel or large vessel involvement, that's okay. There's overlap. Doesn't worry us too much. The only one that involves everything, including the venous side, is Behçet's, and that's not not typically classified as a classic vasculitis, so we're not going to talk about Behçet's. So these are cases that you may see on board. These are kind of classically how these patients will present. So in a GCA patient, they may give you an elderly person with a headache with visual complaints. So until you prove otherwise, that's going to be GCA. Asymmetric pulses in a brewy in a young patient. They may even make it easier and say she's 30 and she's Asian. That's Takayasu's. So that's just check that one off and move on. That's mononeuritis multiplex. Classically is going to be pan. I mean, you can see these with other things, but classically for board purposes, these are the ones you're mainly going to see them in. Pulmonary renal syndrome is going to be Wegener's, which we don't call Wegener's anymore. We'll get to that in a minute. Or MPO-associated vasculitis, the ANCA-associated vasculitides. And then the small vessel leukocytoclastic vasculitis is the palpable purpura. And again, a lot of overlap. But if you have palpable purpura, think about immune complex small vessel vasculitis. So we'll start with giant cell. Probably, depending on who you ask, the most common in the adult population. It's a large vessel vasculitis, also called temporal arteritis. We usually don't like to call it temporal arteritis because that makes people think that it's just here, and it's not. It can involve any vessel, large vessel off the aorta or its branches. And the one that gives you the vision problems is the posterior ciliary arteries, which are not large. So we like to call it giant cell arteritis. Elderly population. Female predominance, but not overly predominant like some of our diseases. And it seems to be a lot more common in northern Scandinavian genetics. So upper Midwest, whites, it's more common. So it's uncommon in blacks, Hispanics, and Asians. So the classification criteria haven't been updated since 1990. So we're still using these old criteria, but they're still okay, I guess. So I said it was elderly. Classically, they're going to be more like 70 or 80. But for the classification criteria, 50 is okay. Basically, if you have an elderly person with any new pain above the neck, think giant cell. Whether that's a headache or jaw pain or tongue pain, scalp pain, any new pain above the neck in an elderly person, think GCA. They may have temporal artery abnormality. You may have difficulty palpating. It may be nodular. It may be beaded. It may be tender. They should have an elevated SED rate. You can have GCA with a normal SED rate. It's quite rare. But they typically will have an elevated SED rate. And you have to remember that in the elderly, you have to correct the SED rate for age, so that kind of throws off what's an elevated SED rate. So typically, a normal SED rate is age divided by 2, or in females, age plus 10 divided by 2. So if you have an 80-year-old woman, normal SED rate for her is going to be 45, whereas on the lab that you get back from lab, it's going to be 20 or 30 maybe. So keep that in mind. And then if you have an abnormal artery biopsy, that can get you into a study of giant cell arteritis. So we already mentioned the clinical presentation is basically pain above the neck. Tongue pain and jaw claudication are probably the most specific for giant cell, although not always present, usually not present. You have to be worried about any new visual changes in an elderly person. And 20 to 40% will have polymyalgia rheumatica with it. Polymyalgia rheumatica can also exist as a separate clinical entity, but often it will overlap with giant cell arteritis. And this is basically proximal muscle group, shoulder girdle, limb girdle, pain, stiffness, elevated SED rate. And fever of unknown origin in an elderly person, you have to think about GCA. Some studies have said that it's 15%. They can also have weird symptoms too. They can have cough, they can have claudication if it's a large vessel like subclavian, and they can have synovitis. So they can have articular manifestations as well. And then nonspecific systemic symptoms, weight loss, fatigue, malaise. So this is abnormal temporal artery. It's nodular, it's enlarged. Right there. What we worry most are the vision changes. Visual loss can happen in 15% of these patients. That number drops quite a bit if you get to them in time and treat them with steroids. It's an ischemic optic neuritis. They can also get amaurosis. It's usually abrupt and painless, which is kind of scary. You don't usually have a lot of warning in these patients. And then we actually cause a lot of vision changes with our treatment because we put these are typically elderly patients. We put them on steroids. Elderly people don't tolerate steroids very well, particularly the high doses that we often have to use in this situation. So it puts them at risk for cataract, glaucoma, and central serous retinopathy. So some of the vision changes are from the disease, and some of the vision changes we probably cause ourselves with our treatment. So the gold standard is temporal artery biopsy, and it's a lecture on itself. When do you biopsy someone who you suspect temporal artery or giant cell arteritis? I have a pretty low threshold because we've all had patients who we think to ourselves, there's no way this is GCA. And then you biopsy them and damn it, it's GCA. So I can't tell you when for board purposes, but generally I have a pretty low threshold. So it's usually done outpatient. You can have oculoplastics can do it, vascular surgery can do it. Just kind of depends where you're practicing. Sometimes if you send them to ophthalmology, they'll say, we don't think this person has GCA. Thank you very much for the interesting consult. And you're like, that's not why I sent them to you. Where if you send them to a surgeon just like, sure, whatever you want me to cut out, I'll cut out. So there it is. You make your little incision through the fascia and pull out the artery there and then snip it out, tie it off, snip it out, and then sew them back up. So it's a pretty simple, pretty quick outpatient procedure. Some centers will do bilateral because there is some data that bilateral gives you a little bit more information because it's skip lesions. It's a patchy vasculitis, so you're liable to miss it. So some places will do bilateral routinely. And then you see granulomas with GCA, hence the name. So that's a giant cell up there. This is the lumen of the vessel, and it's partially occluded with inflammatory debris and fibrin. And then the internal elastic lamina is gone. It's been destroyed. They're pointing at other giant cells, these large cells here. So the treatment is steroids, and more steroids, basically. Generally, you start high dose, 1 per kilo, 60 per day divided BID. Doesn't work quite as well divided, but you can divide it. If there's some data that says that if someone has threatened vision, that you get better outcomes with pulse IV steroids for 3 days. This was pretty bad data, and the people who got the methylprednisolone were on the same steroid dose 6 months later as the ones who got oral steroids. So this is still not proven. Having said that, if I had someone coming in with threatened vision, sure, give them IV steroids, do whatever you can. We generally would start methotrexate at the same time these days for steroid-sparing effect. Because as I said, these patients generally don't tolerate steroids very well. They're at high risk for hyperglycemia, for bone loss, for osteoporosis. They all get edema. It can just be miserable in this patient population. Tocilizumab is a monoclonal antibody to interleukin-6 receptor, and there's really good case report data for its role here. And so who knows, 2 years from now, 5 years from now, we may be using this instead. And then we typically put all these patients on aspirin because they are at higher risk for thrombotic events due to the endothelial disruption. There's a million ways to taper the steroids, but generally you do high dose for at least a month. And then we go pretty quickly down to 20 milligrams a day. You start at 60, you go pretty quickly down to 20 milligrams a day. And then you slow it down to 10 milligrams a day. And then you slow it down again. So it takes a while. Usually they're on this for at least 6 months, maybe a year. Or typically a year. Recurrences are common. Half of patients will have a recurrence, and you just put them back on the next dose of steroids they were at before they recurred, and generally that takes care of it. Almost half require therapy for years. This is a long-term chronic problem condition. Any questions about giant cell? So elderly person, pain above the neck, visual changes, steroids, and biopsy. So the counter, the flip side of giant cell, we said giant cell you have to be over 50, and in practice you're probably more like 70 or 80. Takayasu, you're under 50, and in practice you're probably more like in your 30s. And this is the pulse. You'll hear it called pulseless disease, and this affects the same vessels as GCA, except doesn't affect the intracranial vessels as often. But large vessels off the aortic arch. So here, the right subclavian is basically gone. Let's see. This is what is that? What vessel is missing? This is the brachiocephalic. This is the right common carotid is gone, and then the left common carotid up here. So this causes loss of big, important vessels. Young women, this has a fairly strong female-to-male predominance, unlike GCA. Median age is much younger than GCA, and it is more common in Asians, but has been reported in every ethnic group. And usually presents in three ways. You can have the sort of the prodromal nonspecific fever, malaise, weight loss, and then they get vessel inflammation, and it may hurt, tenderness, pain, and then they get that vessel will scar and fibrose, and then their pulses disappear. So that presents classically with bruise and claudication, decreased pulses, check your blood pressures on both sides, constitutional symptoms. They can get headache, hypertension, and dizziness. Hypertension is renovascular. The diagnosis is difficult to make because there's no, you don't typically get a biopsy like giant cell. The vessels involved in Takayasus are not biopsyable. I mean, you really can't biopsy a common carotid. And there's no antibody. There's no biomarker. And so you're typically stuck with non-specific labs like SED-rate and CRP. Angiography can suggest it if you see the classic findings on angiography. MRA is probably used a lot more often now than angiography. CTA can be used also. And you'll see long segment stenosis or occlusion. And the big problem for Takayasus is that you give them, you treat them, they appear to get better, and then you go back and MRA them a year later and their disease has progressed. And we don't have any way to assess how a Takayasu patient is doing. You would think we could follow SED rates, but the SED rate doesn't appear to matter. These patients will normalize their SED rate just fine, but their disease appears to progress. So this is a problem, obviously. If you have a disease that you can't monitor, essentially we're blind with Takayasus. You can't do angiograms every month. We have a hard enough time getting MRAs the first time, much less for follow-up. So there's some interest in PET scans. They tend to light up at areas of inflammation. So I don't know. I've never done this, but it's probably what we're going to be stuck doing because we don't have any other way to monitor disease activity in Takayasus. Treatment, Very similar to giant cell, basically steroids. Methotrexate is a steroid-sparing agent. You can try Cellcept as a steroid-sparing agent. Severe disease, cyclophosphamide has been used, and TNFs have been used. You'll notice that this is basically every medicine that we use in rheumatology. And anytime you see a disease with the list like this, it just means it's a rare disease, and we have crap data, and so you're welcome to try whatever the heck you want. And many never achieve remission. So, any questions about Takayasu? Okay. So we're going to move on to medium vessel. We're going to ignore Kawasaki. That's a kidney disease. But the classic one here is Polyarteritis Nodosa. This is a medium/small vessel necrotizing vasculitis. We don't know what causes it. It's presumably our standard boilerplate in rheumatology is some environmental trigger in a genetically susceptible host. So probably the same thing here, but it's rare now that we've had hepatitis B vaccination for a while. It used to be most commonly associated with hepatitis B. So PAN is now very rare. A rheumatologist might see a handful. We have 2 or 3. A handful in a career. Internist might see 1, maybe 2 in a career. If you're on white medicine, you're probably done for your career. Importantly, they do not get glomerulonephritis. So if you're trying to figure out what the vasculitis is, like on a board question, if they have active urine sediment, casts, RBCs, creatinine is going up, if they're giving you a nephritic picture, it's not PAN. PAN does not cause glomerulonephritis. PAN does not give you an ANCA. And usually PAN does not give you the lung ENT involvement that you see with Wegener's. So those are important ways to pick out PAN from the other medium vessel vasculitis diseases. PAN likes nerves. So the most common presentation is mononeuritis multiplex. Mononeuritis multiplex is basically you're picking off named nerves. It can be asymmetric, so they'll have maybe a foot drop on one side and a wrist drop on the other side. So that's mononeuritis multiplex. It does affect the kidneys. I said it doesn't cause glomerulonephritis, but it can cause kidney involvement, typically infarcts, renal artery aneurysms, and they can get pretty severe renal vascular hypertension. Skin is common. We have 2 patients active right now with cutaneous PAN. Basically, it's kind of they get nodules that kind of erupt into ulcers, and they get libido. Arthritis, arthralgia, everybody gets arthralgia. Myalgia is common. It can involve the gut due to mesenteric arteritis, mesenteric involvement. They can get elevated LFTs and abdominal pain. They can get MIs, CHF and MI, presumably because of coronary artery involvement. CNS is rare, but they can have seizures and strokes. And then particularly in hepatitis B-associated PAN, testicular involvement tends to be more common. I have no idea why. So the diagnosis is difficult. If someone has hepatitis B in a suspicious clinical picture, that may be enough. They will have elevated sed rate and CRP typically, but mainly you need a biopsy. You need a tissue for diagnosis. Angiogram can help suggest what's going on. If you see mesenteric aneurysms or renal artery aneurysms, that's helpful, but you still probably need a biopsy. So this is mesenteric involvement. And then it's a panmural necrotizing vasculitis. It's pretty aggressive vasculitis. So the treatment is different if you have hepatitis B triggered or non-hepatitis B triggered. So in non-hepatitis B, you basically treat it like any other vasculitis. High-dose steroids. If they've got severe involvement, like they're about to lose a nerve or their gut is infarcting or whatever, then that would be cyclophosphamide. That's our big gun, cytoxin. And then you've got a variety of other things you can use for. If in mild disease, you can use these for induction. In severe disease, you can use these for maintenance. Some interest in infliximab, which is one of the anti-TNF agents we use for RA. The problem with PAN is that it's so rare. We just don't. All this is case level data. There's no randomized controlled studies of treatment in PAN that I'm aware of. If they have hepatitis B, then things are a little bit more complicated. If they don't have hepatitis, you can just hit them with steroids and sort of temporarily knock the disease out. If you do that with hepatitis B, then you markedly increase the chances that their hepatitis B is going to become chronic and they're going to get fulminant liver disease. So you're kind of stuck. You have to give them steroids. You have to get the disease under control, but you generally try to limit it to 2 weeks. So basically you give them high-dose steroids for a week, and then you cut it in half every day the next week until it's gone. So it's a very rapid steroid taper. If they have severe disease, you can do plasmapheresis, because presumably the hepatitis B antibody complexes are what's driving this. So you can do plasmapheresis, and then you treat the hepatitis B, and that essentially fixes the disease. Any questions there? Okay. So we used to call it Wegener's. Now we call it granulomatosis with polyangiitis. There were 2 reasons to do this. One, they wanted the name to more accurately reflect what the disease is actually doing. And 2, Wegener was probably a Nazi. Nobody could really ever prove that. Some rheumatologist with a historical bent a couple of years ago went and researched it. And he was a pathologist who lived down the street from one of the concentration camps in Poland. And he was like best buds with the concentration camp Obermeister or whatever. So, and he was in the Nazi Party, which, everybody was in the Nazi Party then, so that doesn't really mean anything. So there was no real proof that he was involved in the concentration camps, but he probably knew what was going on. So they used the opportunity to rename it. So it's granulomatosis with polyangiitis, classically upper and lower airway involvement. This is this is the opposite of pain, which typically does not give you upper or lower airway involvement. It does give you the glomerulonephritis. So this is classic renal pulmonary syndrome. Classically, you should have an ANCA positive. C-ANCA is the cytoplasmic pattern on immune fluorescent with antiproteinase 3 antibodies. If these line up, if these agree, if you have a C-ANCA and the antiproteinase 3 together in a patient with this, you probably don't need a biopsy. That's probably, the serology itself is very specific for Wegener's in the right clinical situation. Generalized Wegener's is if you have airway involvement and kidney involvement. Limited Wegener's has absence of renal involvement, and you may be able to treat that with less aggressive. Oh, there's Wegener. Probably Nazi. So upper airway, this is tracheal stenosis, and then nodular, sometimes cavitating nodules on X-ray. Eye involvement, not uncommon. They can get this is one of the only diseases that can give you a pan-uveitis. Any layer of the eye can be involved in Wegener's. Nasty, nasty stuff. So this is the C-ANCA. So what's lighting up here that's the nucleus, the little bilobe nucleus in the neutrophil, and the entire cytoplasm is lighting up. So that's a C-ANCA pattern. And then on the right it's lighting up around the nucleus, perinuclear ANCA pattern. And they're pretty good. The problem is that if you have Wegener's, most have a PR3 ANCA, and 96% will have ANCA. This is actually high. If you have MPA, which we'll talk about next, that's more MPO ANCA, and Eosinophillic GPA, which is Church-Strauss, is also more common in MPO, but the number goes down a lot for Church-Strauss. But these ANCAs are pretty good at picking out Wegener's. The problem is that if you have these numbers are higher with renal disease and much lower without renal disease. So if someone has limited disease, upper airway disease, the chances they're going to have an ANCA is much lower. So a negative ANCA in the setting of lung or upper airway disease is not as helpful. You can't really say it's not GPA in that situation. And there's some other things that can give you ANCAs too. ANCAs are actually pretty common. You can get ANCAs with infection, inflammatory bowel disease, medications. A lot of things can give you ANCAs. The difference is that in Wegener's, you have the PR3 with the C-ANCA. The other ANCAs that you get with a lot of nonspecific other stuff are often atypical ANCAs. The one that can really throw things off is endocarditis or intravascular infection. Those will very commonly give you ANCAs and will often give you that PR3 with the C-ANCA and throw everything off. So the treatment of Wegener's depends on extent and severity of disease. If somebody has limited Wegener's, some people do just have skin disease, or they just have sinus disease. And those you may be able to get away with just methotrexate. Some have even used Bactrim because it's felt that in some of these patients, staph colonization drives the disease, and if you treat with Bactrim, some people do really well. corticosteroids most of the time. In severe disease, used to be cyclophosphamide was the drug of choice, and then a couple of years ago we found out that rituximab works really well, and so rituximab is sort of slowly replacing cyclophosphamide as the agent of first choice for GPA. Rituximab is the anti-CD20, anti-B cell monoclonal antibody. So that's GPA. Any questions there? And then its cousin is MPA, Microscopic Polyangiitis. It's very similar, except it has the P-ANCA pattern, which we already mentioned, and it has the anti-myeloperoxidase antibody, typically giving you that pattern. It's also pulmonary renal syndrome. In fact, higher rates of glomerulonephritis with MPA rather than with Wegener's. But otherwise, everything I just said for GPA applies to MPA. Eosinophillic GPA, it used to be called Churg-Strauss. I don't know why they took Churg-Strauss's disease away from him. I don't think he was a Nazi. I think, again, they just wanted to... You already had a GPA, and then they made this eosinophilic GPA, so it just made everything nice and even. If you're going to have an ANCA, it's less likely you're going to have a positive ANCA. If you are, it's more likely to be a P-ANCA and to be the anti-MPO antibody. The classic patient with this is a middle-aged person with asthma, either stable asthma that's suddenly gotten worse or a middle-aged person who suddenly gets asthma. They should have peripheral eosinophilia, but not always. You may not catch it, and this disease can affect anything. Essentially, it's kind of like pan in its distribution. Any questions there? Okay, flying right along. Then we have a whole bunch of small vessel vasculitis diseases, and the clinical finding here is going to be palpable purpura. More palpable purpura. And this is caused by damage to the tiny blood vessels in the dermis that rupture, and then the red blood cells leak out and give you the purpura. And there's a long list of things that can do this. Probably most common is hypersensitivity vasculitis from a drug. We'll ignore urticarial vasculitis. IgA vasculitis is no, not Berger's. It's the Henoch-Schönlein purpura. Cryoglobulinemic vasculitis, we'll talk about. But a lot of things can cause a small vessel leukocytoclastic vasculitis. So Henoch-Schönlein is often on boards. It's a leukocytoclastic vasculitis. It's also associated with possible mesenteric involvement in abdominal pain and give you renal involvement too. You generally see IgA deposition on a biopsy. So if you get a biopsy and they do immunofluorescence for immunoglobulins, you'll see IgA deposition in the wall, which can be helpful. Classically, this follows an upper airway infection, which kind of fits because when you have an upper airway infection, that's mainly an IgA. IgA is a response to mucosal infections. So if you have an upper airway infection, that's the thought, is that you get some infection that triggers an IgA response, and then you get this vasculitis. So they get purpura, abdominal pain, arthritis, and 80% will get renal disease. This is much higher than in kids. When you see kids with HSP, the renal disease is much lower and much less severe. But for some reason in adults, it tends to have a worse course. Treatment for mild disease, if they just have some arthritis and some abdominal pain, you give them NSAIDs. Generally corticosteroids for more severe disease or corticosteroids for renal disease. If they have bad renal disease, they can't get full-blown glomerulonephritis, then you would use cyclophosphamide. So cryoglobulinic vasculitis. So what are cryoglobulins? What is a cryoglobulin? What's a rheumatoid factor? Right, it's an antibody to another antibody. Cryoglobulin is a rheumatoid factor that basically precipitates into complexes at temperatures less than body temperature, and then dissolve again when they're rewarmed. That's kind of the definition of cryos. And there's three kinds. The first one is a monoclonal. You have a monoclonal immunoglobulin, and that's almost due to a blood dyscrasia, like a Waldenstrom's macroglobulinemia. So we won't talk about that one anymore. And then the other two. Type 2 is a monoclonal IgM to polyclonal IgG, and type 3 is a polyclonal IgM to polyclonal IgG. And these are the ones associated with infection, classically hepatitis C, and with underlying connective tissue diseases. So type 1, they present in different ways. Type 1 is hyperviscosity syndrome. Raynaud's and thrombosis, they can get headaches and dizziness. The other two, they're so-called mixed essential cryoglobulinemia. The classical presentation is palpable purpura, arthritis, Raynaud's, and renal disease. And then sometimes they can get neuropathy, and it's usually a painful sensory neuropathy. So on labs, some helpful labs, well, you want to get a cryocrit, which if it's negative and you really suspect it, they may still have cryos because it's a difficult test. It's a difficult test to do because these cryoglobulins start to precipitate as soon as the temperature drops. When they draw these, the phlebotomist has to draw it. They have to have a pre-warmed container of water that's 98.6, has a little thermometer in it. And they have to draw the specimen and then immediately put it in that pre-warmed container. They have to keep that at 98.6 until they get it to lab, and then they let it cool down for an hour. If they let it cool down prematurely, then the cryoglobulin precipitates out of serum, and you will get a false negative. So you can imagine you're the phlebotomist at university or wherever, and you've got 20 patients to stick, and you're busy. So because this is negative, it may not mean that it was actually negative. It may mean that the phlebotomist just didn't keep it at the right temperature for long enough. Maybe it sat in the collection, the specimen rack in the lab for too long or something. So it's a difficult test to do properly. Some other tests that can be helpful, these patients should all be rheumatoid factor positive because these are antibodies to other antibodies. They all have rheumatoid factor activity. So most will be rheumatoid factor positive. They probably will have low complement levels, particularly C4. C4 will be reduced out of proportion to C3. And then you'll see just generalized on your CMP, you'll see generalized hypergammaglobulinemia. They also, just to confuse things and keep it interesting, these patients will often have other antibodies because this is a disease where immunoglobulins are just revved up like crazy. And so up to half of the time they'll have ANAs, they'll have ANCAs, they'll have antiphospholipids. So these are not pathologic antibodies, they just exist because of this generally revved up immune response. So the treatment kind of depends on the underlying disease. If they have severe disease, corticosteroids and plasma exchange. If they have severe disease, cyclophosphamide, like if they have neuropathy or glomerulonephritis, you would use cyclophosphamide. Low antigen diet has actually shown pretty good results in these patients. This is like dairy-free, gluten-free. It's a strange diet. Rituximab works really well. And so rituximab, not only for Wegener's but for cryos, is probably going to become the agent of choice in severe disease. And then if they have hepatitis C, you treat the hepatitis C. If you don't treat the hepatitis C, this is just going to smolder and continue and never go away. Any questions there? Mm-hmm.
Usually when we're thinking cryo, it's someone with hepatitis C, or neuropathy, and usually we don't trust the cryo. Mm-hmm. How specific is rheumatoid factor, and can we trust the high value or low value?
I don't know the specific specificity, but I will say that I almost always now ignore cryos when negative. And if they have a high titer rheumatoid factor and a low C4 in the right clinical picture, then that's pretty suggestive. And once you have a cryocrit, it's you can't really follow it. So if somebody has a cryocrit of 10% and then you treat them and it's 5%, it doesn't necessarily mean they're not getting better. There's very little correlation between how they're doing clinically with the cryocrit itself. So cryocrits are kind of a mess. So I'm sorry, I can't tell you the exact specificity. If it's positive, yeah. If it's there, I trust it. If it's not there, then I rely more on, do they have a rheumatoid factor? Is their C4 low? But unfortunately, up to half people with hepatitis C will have a rheumatoid factor anyway,
right.
because
we like to attribute the neuropathy to something like cryo.
Right. Well, then you're kind of stuck. Then you have to get a biopsy or if their complement, if their C4 is really low, then that may be suggestive. But yes, up to half of patients with hepatitis C have a low-level cryoglobulinemia and have a positive rheumatoid factor. So in that situation, you're kind of stuck. Okay, drug-induced vasculitis, very common. What illicit drug is this that this patient took? I heard some mumbling. What'd you say? Cocaine, yes. It's not actually the cocaine that causes this, it's the levamisole, which I have no idea why they cut cocaine with levamisole. But levamisole is an antihelminthic that is an immune modulator. It's an immune stimulant, supposedly. It's apparently widely used in Eastern Europe and Russia. Like if you get a cold, they'll give you levamisole. But levamisole has this well-described vasculitis associated with it. Likes the ears. So that's cocaine-induced vasculitis. That's cocaine-induced vasculitis. So particularly if you have a patient with these sort of dark vasculitic necrotic lesions, particularly the ears and nose, get a urine drug screen. Other biggie would be propylthiouracil. Could give you an ANCA-positive, a fairly severe ANCA-positive vasculitis. We've had one patient die with this. Methimazole, hydralazine is probably the most commonly used on this list. Well, maybe minocycline for acne. And then we mentioned cocaine. These will give you an atypical ANCA, meaning a typical ANCA looks different on immune fluorescent. And so this will be an atypical ANCA, and it will often give you an ANCA mismatch. Whereas normally when you see a C ANCA, you would expect to see PR3, and if you see a P ANCA, you would expect to see MPO. If you have the opposite, if they don't match up, then think about a drug-induced vasculitis, particularly cocaine-induced vasculitis. But also cocaine-induced vasculitis can give you all three. Many of these patients will have a positive ANCA and a PR3 and an MPO. And then I wanted to briefly, any questions so far there? Okay, and then I wanted to briefly mention this, because we get called a fair amount of the time for when someone gets a CTA or an MRA and radiology says, oh my God, it looks like cerebral vasculitis. So primary angiitis of the CNS, and here I'm talking about primary angiitis, not CNS vasculitis associated with, for instance, lupus. Classic primary angiitis of the CNS is typically a middle-aged male, and it has an insidious onset. This is not a thunderclap headache. This is not a sudden, oh my God, loss of vision headache kind of thing. This is usually an insidious process, probably from chronic meningitis. They may have focal neurologic deficits and a slowly evolving encephalopathy. MRI is not very good, but if it's normal, then it's very helpful. But the changes you see on MRI are not very specific. You may just see white matter changes, which you can't tell if those are old hypertensive changes or what. But if the MRI is normal, that's helpful. And imaging angiographic imaging is terrible because there's a lot of things that can look like this. So neurology will see this and call us and say it's CNS vasculitis. And if you actually look at the literature, it's almost never CNS vasculitis. It's almost always something else. It's also difficult because your acute phase reactants are not helpful. CSF is helpful if they have a negative CSF protein. It's difficult to have CNS vasculitis with a normal CSF protein and a normal MRI. The MRI, like I said, though, is almost always abnormal, but is horribly nonspecific, and an angiogram has a very low predictive value. So most places these days who most refer, like Cleveland Clinic is the big vasculitis center in the country. They just get brain biopsies because they've learned that even if you have the classic bead on a string on angiogram, when you biopsy those patients, it's almost always something else. Most likely it's going to be reversible cerebro-vasoconstrictive syndrome, which is kind of like a mega migraine. It's going to be PRESS, posterior reversible encephalopathy syndrome, which is another sort of, these mimics all involve blood vessel overactivity, and that's what both of these are. Benign angiopathy of the CNS, sex-associated, exertional, migraine-associated, postpartum angiopathy. These can all give you that bead on a string picture. Infections will commonly do this. Herpes, HIV, zoster syphilis. CNS lymphoma is often diagnosed in a patient who appears to have classic CNS vasculitis on an angiogram, but then they do the biopsy and they've got CNS lymphoma. And then drugs will do this. Vasoactive drugs will very commonly give you this presentation. So if you have someone you suspect CNS vasculitis, I'm not saying that it's not CNS vasculitis, and it's still okay to call us. But don't get mad at us when we say it's not CNS vasculitis. Neurology, I think, gets irritated with this. Any questions?